Hello everyone. In this video we are going to explore the medications that are used in Parkinson's disease. When we talk about medications for Parkinson's disease, we're going to talk about several different types of medications treating several different things that occur in Parkinson's disease. So here we are with the Parkinson's disease medications. We've got dopamine replacers. Dopamine replacement, we're talking about a medication like levodopa-carbidopa. Then we have dopamine agonists. After that, we talk about COMT inhibitors. We'll move on to the MAO-B inhibitors. And then finally, the dopamine releasers. Do you remember what the dopamine replacement drug was that we talked about in class? If you said levodopa-carbidopa, you are exactly correct. Levodopa is something that once in the body, it converts over to dopamine. Carbidopa is something that when it's added to levodopa, keeps the levodopa from breaking down as much in the body before it gets to the brain. So it leaves more levodopa for the brain where it's needed. There are several dopamine agonists in our book. If you remember what a dopamine agonist is, all you have to do is remember what an agonist is and what dopamine is. Dopamine is a catecholamine, right? And an agonist is something that mimics a body chemical. And/or it's a helper to the body chemical. There are two main categories of dopamine agonists. There are the non-ergo derivatives, and there are the ergo derivatives. It's all in what it's been how it's been derived when it was made. The non-ergo derivatives, non-ergo dopamine agonists, can you list them from memory? If you said apomorphine, pramipexole, ropinirole, and rotigotine, you are correct. The ergo derivatives. the ergo-dopamine agonists. Can you list them? I'm going to give you time to list them. Okay. If you said bromocriptine and cabergoline, you are absolutely correct. The next set of medications we're going to talk about are the COMT inhibitors. Okay? Can you list the COMT inhibitors that you learned about? You said entacapone and tolcapone. You are absolutely correct. Can you list the MAOB inhibitors? If you said rasagiline and selegiline, you are absolutely correct. Finally, we have a category called the dopamine releasers. Can you tell me one of the dopamine releasers that we learned about in class? If you said amantadine, you are absolutely correct. Now we're going to work on the next part of your memory, which is recalling what the mechanism of action for each of these is. So we're going to look at the dopamine replacement, levodopa, carbidopa. What's the action of levodopa, carbidopa? What is that mechanism of action? All right, let's talk about this. So we've got a person here, and we give that person levodopa. We give it to them orally. It goes down, it gets absorbed, goes through the body, and it goes to the brain, right? That levodopa, once it goes into the body, gets converted to dopamine. And it actually replaces the dopamine that's missing in the brain. It's not entirely missing, but it's lacking. Carbidopa helps so that the levodopa doesn't get broken down in the periphery, and then that means we have more levodopa that gets broken down in the brain. That's its mechanism of action. What's the therapeutic role of dopamine replacement? The therapeutic role of dopamine replacement is to decrease those cardinal symptoms that are motor symptoms of Parkinson's disease. So it helps to decrease the tremor, rigidity, postural instability, slowed movements, the dyskinesias. Dyskinesias are abnormal movements. Dyskinesias happen when there's damage to the extrapyramidal system, and these can be fixed by replacing the dopamine that's missing. The mechanism of action of dopamine agonists are very similar to the dopamine replacement. It's just that they're mimickers. So they aren't actual dopamine, but they mimic dopamine. Their therapeutic use is the same. It's to decrease those abnormal motor symptoms of Parkinson's disease. Please note that pramipexole and ropinirole are really truly first line or supplement to levodopa. Those two are really the choices that are being utilized. Apomorphine is beneficial when you need some kind of a sub-Q agent. Sometimes people don't always take oral meds, but apomorphine is really good as a rescue during some off times, and these sub-Q injections can be very helpful in that respect. Ergo derivatives are a little older and are generally nowadays we avoid them a little bit more than the others. Now there's a challenge. Can you tell me the mechanism of action of COMT inhibitors? If you said they inhibit the breakdown of levodopa by COMT, you're correct. COMT is referring to one of those enzymes that can break down levodopa, and these are drugs that can inhibit that. Therapeutically, how are these used? If you said that these are used to decrease the wearing off of levodopa, you are correct. Which one is more effective? Entacapone is more effective and safer than tolcapone. All right, another challenge for a gold star. How do MAOB inhibitors work when used for Parkinson's? What's that mechanism of action? If you said they inhibit the breakdown of dopamine by MAOB, you are very correct. Once again, we're referring to MAOB as an enzyme that would break down dopamine, and these inhibitory drugs would inhibit that enzyme from doing so. So therapeutically, what are these MAOB inhibitors used for? If you said that rasagiline and selegiline, the MAOB inhibitors, are used in these newly diagnosed patients, and also for people who have kind of off times between the levodopa therapy, you're correct. All right. Another gold star question. Tell me the mechanism of action for amantadine, which is a dopamine releaser. If you said that amantadine, a dopamine releaser, would promote more release of dopamine from remaining dopaminergic neurons, and it may also block the reuptake of dopamine back into those neurons, you are correct. Therapeutically, it may help to reduce those levodopa dyskinesias that are actually caused by the levodopa itself. Most people will ask themselves, I thought we were trying to treat dyskinesias. Well, sometimes people can kind of have that paradoxical response as well. That being, maybe we've kind of pushed the envelope a little far with the levodopa. These dopamine releasers can assist with that. There are life stage considerations when we're talking about treatment of Parkinson's disease. There are different categories that are specific groups of people that we need to talk about. So we need to talk about kids, we need to talk about pregnant women, and then we need to talk about breastfeeding, and the part that I'm going to leave the most room for is the older adult. Let's talk about the older adult first. Do you remember what the average age of the person with Parkinson's disease is? On average, somebody with Parkinson's is usually older than or equal to 62 years old. And on average, I'll rephrase that because I don't think I quite said it right. The average age of diagnosis for Parkinson's disease is 62 years old. Most of the prescriptions that are given for Parkinson's disease are given to this portion of the population. The most people getting these Parkinson's disease medications are 62 years old or older. So in the older populations, you have a higher risk than in the younger populations of adverse reactions. That's just how it is. Anticholinergic drugs can have a lot of adverse effects in older populations, but we still use them because a risk benefit is that kind of an analysis is done. So be thinking about that when you look at these medications and you're learning about these medications, is that doctors and their patients look at risk benefits, and really good education about these medications to people and families is really needed. Children, so kids don't usually get Parkinson's disease. This tends to be a disease that is progressive and occurs with age, not something that occurs in young children. Amantadine, benztropine, and bromocriptine are the only ones that have approval for kids. Selegiline is an absolutely contraindicated in kids younger than 12. For pregnant women, bromocriptine and cabergoline aren't associated with terribly adverse outcomes, but the manufacturer still recommends that we stop them if somebody's pregnant. Animal studies really tell us that the rest of the meds are all really bad as far as the fetus is concerned. Ropinirole is extremely teratogenic, meaning that it's extremely harmful to the fetus. Now, moving on from that, now we can look at the breastfeeding side. Bromocriptine and cabergoline they interfere with lactation. Anticholinergics like benztropine can also suppress lactation. Breastfeeding isn't recommended for women taking these medications. We're going to go back and talk about dopamine replacement. And in dopamine replacement, we're going to look at levodopa-carbidopa. And can you tell me what the adverse effects are? Some of the adverse effects of levodopa-carbidopa include nausea, vomiting. They include dyskinesias. And remember, that's paradoxical, right? Some cardiovascular effects, which can include, so I'm going to put a heart here, a postural hypotension. And if you remember what we do for postural hypertension, we encourage salt intake. And we encourage that because we want more salt and water. So we encourage salt and water intake. We want more salt and water to fill up the vasculature. Sometimes psychosis can happen. You can see hallucinations, sometimes vivid dreams or nightmares. Vivid dreams and nightmares are really actually common with this. Paranoid ideation. So people can tend to have that. There can be side effects, adverse effects, that include agitation and memory and cognitive impairment. So I'll put agitation and cognitive issues. One thing that we do want to tell patients who are getting this, teach them about this, is that this will, a side effect is that it will darken the urine. And in an individual already feeling self-conscious about all these motor symptoms that they're having, it's good for them to know that they might want to buy more dark colored clothing because it won't show the stain from urine and sweat that is darkened. The sweat also is darkened. There are drugs that interfere and interact with levodopa. And generally, we've already talked about a lot of these drugs that would interfere and interact with levodopa. And sometimes we like to give them to make levodopa-carbidopa work even better. So drugs that increase the beneficial effects of levodopa are things like carbidopa and tacopone or talcopone, rotigotine, apomorphine, bromocriptine, cabergoline, primopaxol, ropinirole, amantadine, and anticholinergic drugs. Drugs that decrease the beneficial effects of levodopa can include some antipsychotic drugs. Drugs that increase levodopa toxicity, maybe the MAOIs. So some of the MAOIs that are utilized for things like depression can increase risk of extreme hypertension. Pyridoxine, or B6. Let's talk about the relationship of B6 and levodopa. Okay. So pyridoxine, or B6, does accelerate the breakdown of levodopa in the periphery. But because levodopa is now combined with carbidopa, that interaction isn't as much of a concern. It's still a slight concern, but it's not as much of a concern because the carbidopa does actually prevent some of that breakdown that the B6 is actually helping to perform in the periphery. Let's recap a little bit, okay? Let's recap a little bit about Parkinson's disease. And let's first start by asking you, what are some of the things that you would assess in a patient, or your NCLEX calls it client, with untreated Parkinson's disease? If you said tremor, at rest, rigidity, postural instability, bradykinesia, and some other motor symptoms like autonomic dysfunction, sleep disturbances, depression, psychosis, and dementia. If you said all those things, you are absolutely correct. And so when we're giving medications, the therapeutic effect would be to see those symptoms reduced. So let's recap again. And I'm going to recap by asking you a question. What is the pathophysiology of Parkinson's disease? Let's look at Parkinson's disease pathology. If you said it's a degeneration of the substantia nigra neurons, that would supply dopamine to the striatum, you would be correct. What we end up with is an imbalance of dopamine and acetylcholine. Please go back to the beginning to replay any of the medication information that you need to recap on. Remember, your exam can include anything in the readings, anything in the recordings, anything in class, and anything in the modular information in the classroom. Have a great day.